morning, everyone. I would also like to thank the organizing committee for organizing and allowing me to speak and present this case. So this case is a boy who presented to us at the age of 5 years. He was born to non-consanguineous parents of Jewish descent, and the family history was negative. Now, the phenotype at the time of presentation was dominated by recurrent fevers, general malaise, arthralgias. He wasn't growing, so his linear growth was stunted. And the most predominant feature of his phenotype was a splenomegaly and a generalized lymphadenopathy. So multiple lymph node stations showed multiple lymph nodes that were enlarged for larger than a centimeter. Laboratory analysis showed predominant systemic inflammation also, so it raised levels of sedimentation and CRP levels. He was anemic at the time of presentation, and he had elevated platelet counts, so he had a thrombocytosis and marked hypergammaglobulinemia. His albumin levels were also low. What you can see here is our PET CT images, so you can see the cervical lymph nodes on the left, top left. Then here you can see the splenic uptake as well. Here you can see the axillary lymph nodes that are clearly shown, and then the inguinal lymph nodes also. They were enlarged and inflamed. A lymph node biopsy was taken, even though the oncologist didn't think it was suggestive of something malignant. But of course, since the lymphoproliferation was so predominant, biopsy was undertaken. The pathologist described atrophic germinal centers with an expanded mantle zone, but the architecture was preserved and there was no plasmacytosis present. So we asked him to do some additional cytokine stainings as well on these biopsies. And while a reactive lymph node is positive for TNF-alpha, this wasn't the case in the lymph node of our patient. However, IL-6, which is seen in green, it's not very clear, I think, with the light, but it's clearly in the germinal center of the lymph node, but also in the case of the patient, outside by different cells, there's also production of IL-6. So in conclusion, we had a patient who was presenting with systemic inflammation, fever, predominant lymphoproliferation, and had hypergammaglobulinemia. So the clinicians kind of marked this as a Castleman-like disease. Now I say Castleman-like because he didn't fulfill all of the histopathological criteria to really call him classical Castleman. But as you see, you need to fulfill both major criteria for this diagnosis. And one of these is the enlarged lymph nodes, so that criteria fits perfectly. But the histological features, you need at least grade 2 or 3, and in his case, these were grade 1, graded by our pathologist. But when you look at the laboratory features, so you only need 2 of these 11, and out of these laboratory features, the 6 that are mentioned here, he had actually all of them, except for the renal dysfunction. And for the clinical findings, he also had the large spleen and the constitutional symptoms. So I think we can definitely say it was a Castleman-like phenotype clinically. We also did some cytokine measurements in his plasma. Now the marked dotted line is where we initiated treatment, so I'll come back to that in a minute. But as you can see, levels of IL-6, IL-18, TNF-alpha, and IL-1RA were all elevated before treatment and then went down after treatment. So to our surprise, when whole exome sequencing was undertaken in this patient, we found homozygous mutation Gly47R. I think it's already been mentioned. It's the common mutation in the Jewish population. And the predominant phenotype that had been described at the time was the polyarthritis nodosa phenotype. And there was no signs of that at the time in our patient. And actually, we undertook then screening in the entire family many years later and found that this older brother had the exact same homozygous mutation. He's been checked clinically and biochemically, and there are no signs at all of any symptoms so far. So hopefully it stays that way. Thanks to Dr. Michael Hirschfield, then we also checked the plasma ADA2 enzyme activity, which was decreased as expected in our patient, and this was also the case for the older brother. In light of those findings, then we did an MRI of the brain more recently, which was negative. So this is one of the rare patients that was actually treated with tocilizumab. So I don't know if it's very clear, but you can see, first steroids were initiated, so his systemic inflammation was already starting to come under control because of the steroids, but we actually had sustained remission, and after that we were able to taper steroids very easily. And his sedimentation, his CRP levels normalized, his hemoglobin normalized, and hypergamma, this also disappeared with the initiation of this treatment. And his growth also improved. So when I looked back just at some other case reports, it was mainly from supplementary tables from previous reports. There have been some patients treated with tocilizumab, but the outcome either was not available or was not particularly favorable. So you can see here, this patient here was refractory and died 2 months after diagnosis. Another patient, there was 2 brothers that were treated, and in one of the 2 patients, there was a recurrence of stroke within 2 months after initiation, so the treatment was stopped. And in this other patient, there was no response at all. So we definitely don't advocate starting tocilizumab in these patients. So how has our patient been doing so far? So we actually have sustained remission in this patient after 4 years until, very coincidentally, since 2 weeks, he's actually presented to the emergency care with an acute vasculitic ischemic lesion of the testis. So he presented actually with pain upon palpation of the testis, so not spontaneous pain. And upon examination, it appeared also bluish in color, and it was swollen. So the ultrasound was immediately performed, and it was actually suggestive of a torsio of the testis. So they immediately rushed him to theater, but they didn't find any torsio when they did an explorative surgery. And they took a biopsy, and this biopsy did show that there was an inflammation in the vascular wall and that it was an ischemic event. So they started him on steroids, and actually since then he's doing quite well just with the steroids, and they're thinking now of switching the therapy to Enbrel, which hasn't occurred yet. So in conclusion, I think we can say here we do have a novel mimic for idiopathic multicentric Castleman's disease. And already there's a lot of mimics in the group of autoimmune autoinflammatory diseases, as you can see here. But of course, ADA2 was not included in that list thus far. And our patient remains free of recurrent infections. I think you can see as well from the CRP sedimentation levels over the course of the 4 years. He did 1 viral infection in those 4 years and is doing otherwise well. So this case raises a number of questions, I think. Since the wide variety of clinical phenotypes that we have with ADA2, it's really the case, when do we not consider ADA2 in our patients? Even in the absence of vasculopathy and even with unusual features such as hyper-IgG. The phenotype of ADA2 apparently can change in the same patient over time. So what we're seeing now with this torsio testis type phenotype was actually a ischemic lesion. And finally, the optimal treatment for ADA2, I think the consensus indeed is that anti-TNF treatment should be initiated, but maybe it needs to be tailored to the phenotypic presentation, as tocilizumab was effective in our patient for 4 years. So it does raise a lot of questions. Thank you very much.